Thank you. Two of my trainees, Jordan Sisson and Bhoomi Patel, will be presenting the presentation, our findings today.
Hello, everyone. Thank you for allowing us the time and opportunity to present to you today. My name is Bhoomi Patel, and I'm presenting with my classmate Jordan Sisson on the framework for preparing clinicians for the challenges of the opioid crisis. So before we begin, we would just like to say thank you to NIOSH as well as the New York and New Jersey ERC for the funding provided to do this pilot project. So the opioid epidemic is not lost on anyone. However, for these past few months, because of the ongoing pandemic, it's definitely taken a back seat. This is a recent headline that exemplifies the magnitude of the current opioid epidemic in the United States. Big lawsuits filed and settled against pharmaceutical companies that just this year were producing and promoting opioids. So why is this concerning? 20% of Americans deal with chronic pain compared to 10% of Americans who have diabetes and are frequently featured in mass media. So despite twice the prevalence, chronic pain is not talked about nearly as much as diabetes is. An average worker is absent from work 10.5 days compared to a worker who misuses opioids who will miss on average 29 days of work per year. 95% of deaths that are related to opioid use occur in working age adults. Many times, people who are most likely to receive an opioid prescription in clinics have a history of lower back pain. The number of individuals with lower back pain and who use opioids is startling. Those who are dealing with chronic lower back pain and who are prescribed an opioid are twice as more likely to misuse heroin, methamphetamines, and cocaine. So why is this a problem? Historically, in the 1980s and 1990s, studies were conducted poorly to justify the use of opioids with non-cancer patients, as well as the introduction of pain as a fifth vital sign. Currently, there's a poor integration of mechanisms of pain by healthcare providers. It's also not well addressed in current health science curricula. Mental illness is a comorbid condition associated with chronic pain, and many of times those who seek care in the emergency department are provided with very few treatment options other than opioids. So our purpose was to survey students in the healthcare graduate programs on their beliefs and knowledge of pain neuroscience. We used questionnaires to scope out any gaps in knowledge and maladaptive beliefs in students. Using the gathered data, we hope to develop and adapt pain neuroscience education curriculum, and we hope to use this information to create a targeted curriculum for each specialty with evidence-based information. We conducted our research with a Qualtrics survey to all Toro Health Science students in all years via email. We sent an email to the PT, DO, and nursing programs at both Toro College and New York Medical College. Our survey had two questionnaires, the HC pair and the NPQ. The HC pair is a valid and reliable tool of 19 questions using the Likert scale. The NPQ, another valid and reliable tool of 15 questions with 3 responses of true, false, and undecided. A bit about our demographics. We have 99 people originally included in the analysis, but not all 99 completed all parts of the survey administered. Of our demographics, we had a relatively even split between both male and females, but an uneven split between the DO and PT program. About twice as many students reported to have no clinical experience to some clinical experience. And when students were asked on the belief if P&E is an effective treatment for chronic pain, most answered yes. But when asked if they felt academically prepared to administer P&E, the majority said no. And finally, asked when in clinic if they saw patients with chronic pain and the use of P&E treatment, less than half reported seeing any utilization of the treatment during clinic. My classmate Jordan will now further discuss the data.
Thank you, Bhoomi. As Bhoomi mentioned before, we administered 2 surveys to collect information from our research pool, one survey being the HC pairs, which I will go into more detail about now. The HC pairs is a questionnaire that measures attitudes and beliefs about pain. Lower scores on the HC pair indicate that the individual is aligned with what we know to be true regarding pain education. Higher scores indicate a pathoanatomical or biomedical understanding of pain, which is malaligned with the pain evidence. The HC pairs uses the Likert scale, and if you're not familiar with that, it's a grading system that indicates how much the individual agrees or disagrees with the statement. The Likert scale goes from 1 to 7. Scores from 1 to 3 are aligned with the evidence, while 4 to 7 are more aligned with biomedical pain beliefs. 4 is the cutoff point, which is considered neutral and a malaligned belief, because as a clinician working with chronic pain patients, it is simply unacceptable to have no beliefs when it comes to pain. Highlighted in purple at the top of the slide is the participants whose beliefs are not aligned with the evidence. And you can see the mean score for these participants is 4 and above. When we analyzed the responses, we saw that out of all 15 questions on the HC pairs, 7 of the questions are on the side of maladaptive beliefs. Very few questions were answered correctly, and it's also concerning to note that none of the questions were answered with complete certainty. The overall scores on the HC pairs can range from 7 to 105, and the mean score for our sample was 57.1. So this next slide looks at the data we collected from the NPQ survey. In contrast to the HC pairs, the NPQ strictly measures knowledge of the physiology of pain. The data in this chart is sorted from most incorrect to least incorrect. And as you can see, a third or more of our subjects got at least 50% of the questions wrong. So now that we have discussed the answers to our primary research questions, we can dive a little deeper into the data to look at correlations of interest. We wanted to see if there was a relationship between scores on the HC pairs and scores on the NPQ. And as expected, a lower HC pairs score is correlated with a higher NPQ score. Then we wanted to see how students with and without clinical experience performed on the 2 questionnaires. So we compared the scores from students who had 16 or more weeks of clinical experience to students who had less than 16 weeks of clinicals. And as expected, we found that students with more clinical experience had significantly better scores on the HC pairs than students with less clinical experience. However, we didn't see any significant difference between NPQ scores in these 2 groups. As you saw before in the demographics section, we asked students if they felt academically prepared to administer pain neuroscience education treatment to patients, and the students that said that they do possess the skills to treat patients with chronic pain demonstrated better scores on the HC pairs over students who did not feel that they had those skills. The last question we wanted to ask from our data was, how do students from different healthcare specialty programs perform in comparison on these 2 surveys? We found that PT students scored significantly higher on the NPQ than osteopath students. To go into our discussion, the overall score on the HC pairs indicates that students don't really have any beliefs regarding pain education. Almost half of the questions people scored on the malaligned side of the evidence, and listed below are the 3 questions that were most aligned with the evidence. So I'll give you guys a second to read over those if you wish. If we look over at the NPQ, we see that about 30% of students answered more than 50% of the questions incorrectly. And more concerning than that, more than 60% of students answered more than 20% of the questions incorrectly. 100% of students answered the following statement correctly: pain only occurs when you are injured. The correct answer to this statement is false. More than 90% answered the following question incorrectly: when part of your body is injured, special pain receptors convey the pain message to your brain. The correct answer to this statement is also false. So these are 2 questions that we can look into further. To conclude, the main takeaway here from the research data is that our data shows maladaptive pain attitudes and beliefs and a lack of PNE knowledge in our sample. Only 41% of our subjects have seen PNE applied in the clinic. This is important because knowledge and beliefs guide clinical decision-making, and pain education is needed to guide correct clinical decision-making. Therefore, questionnaires like this provide useful data for developing a pain curriculum, and adequate training of all clinicians is needed so that they are more prepared to effectively manage those with chronic pain without opioids and restore full function, including work. The limitations of our study, as many presenters said before, COVID-19 interfered with data collection, which also led to a lack of a diverse subject pool. The length of the survey and the wording of some questions might have been a deterrent for some students, and there are no standards currently for PNE, so we can't necessarily judge these students based on their performance on the 2 surveys. We hope to take our research further to gather more data to develop a successful pain neuroscience education curriculum to be implemented in the future. The first step in doing so would be to acquire funding that will allow us to develop this curriculum and implement it into our programs. Then we must re-administer the 2 surveys to a more heterogeneous cohort. The last step would be to find a group of interdisciplinary educators who will develop and implement a targeted curriculum that supports the evidence of their practice. Thank you for your time and listening. We hope you found our research interesting, and we'll open up the floor for any questions now.
Okay, thank you very much. I think Amy has a question. Amy, please remember to unmute.
Yeah, I was just wondering about the nursing response, because it looked like you had sampled nurses but didn't have any respondents.
Yeah, so we sent the surveys out to nursing students, and due to the pandemic, they were just inaccessible, unfortunately.
Thanks.
Any other questions?